respectable chairperson, ma'am, who has gone, my dear colleagues, ladies and gentlemen, अस्सलाम वालेकुम। सबसे पहले तो चीमा साहब का, आफ्ताब साहब को और आपकी सारी टीम का बहुत शुक्रिया for giving me this opportunity. I think credit goes to you for arranging such wonderful academic sessions, to have so senior faculty members over here. So all praise for you. The topic I'm going to share with you, the challenges in the diagnosis and management of cervical carcinoma. You all know this is the third most common gynae problem after endometrial and ovarian cancer. If you look at these images, I'll just move this cursor here. Irrespective of the age, as you go from the fundus down to the cervix, you can see here the vagina, the external os. The cervix starts gradually decreasing in transverse diameter and in the epidiameter. It's half of this fundus over here and cervix. So that means this diameter should be less than 2.5, 2.3 centimeter in a post-menopausal woman. If it is a large, look at this again, its fundus is high, gradually coming down level of internal os, and there we go in the external os, and this is epidiameter is 2.4 centimeter, and well-defined smooth outline, tapering gradually uski hoti hai. So that is a normal cervix you should appreciate on transabdominal and on transvaginal route. But if you add a 3D ultrasound, just one click away, you can see the entire endometrium starting from the fundus down to the cervical canal. And if there's anything wrong, irregularity, especially at the margins, you can appreciate that. In this case, you can appreciate the small echogenic focus, which is basically a polyp within the uterine cavity and not a mass. Just to show you the how the images they look like on ultrasound and MR. Look at the cervix and look at the MRI. You can appreciate this uterine cavity, and that is the cervical canal. Very nicely appreciated on the coronal as well as in the sagittal and the axial sections. And if it is irregular, thickened, now let's start how the presentation of the cervical cancer. It may be younger age, often asymptomatic, post-coital vaginal bleeding, abnormal vaginal bleeding, and profuse malodorous vaginal discharge, is foul-smelling discharge. If you find these three things, one should start worrying for this cervical malignancy. There are multiple causes of bulky cervix, maybe cervicitis, the most common. It can be cervical fibroid, it can be endometrial polyp, it can be Nabothian cyst, it can be cervical ectopic, these days we are looking for it, or these are the malignant conditions, and out of that, 90% is squamous cell carcinoma, which is the ectodermal origin, which you can see downstairs. So I limit myself only to how to diagnose this malignant condition, and I'll omit this benign condition because of the time. We all know by the latest classification of cervical cancer, there are 4 stages, 1, 2, 3, 4. I'll just show you image here, 1A image. The tumor is limited to the cervix, there you can appreciate the cervix, and depth and width determines the substaging. And it has to be less than 3 millimeter or more than 3 millimeter in 1A, and 1A2 if it is more than 3 but less than 5 millimeters. Similarly, 1B, if it is limited to the cervix, but the depth of the this invasion is more than 5 millimeter. That is 1B stage. 2 stage, if the tumor involves upper third of the vagina without parametrial involvement, then you can appreciate the upper third of the vagina is involved, but there is no parametrial. But if you go to 2B, 2A, only this side wall, but if you see the parametrium, include the parametrial involvement, that is stage 2B. Stage 3, the lower vagina is involved without pelvic wall. And stage 3B, it not involves the vagina but involves the pelvic wall, and that involves the base of the bladder, with the result there is hydronephrosis. The first thing involved picks up as the extension to the bladder is the base of the bladder where all the ureteric jets are entering and that causes hydronephrosis. So patient may present to you with even hydronephrosis without this local complaint. In stage 3C, it's metastatic, both lymph nodes, either in the pelvic cavity or in the para-aortic lymph nodes. Again, if you go further, then I'll share with you the next stage. Stage 4, if it involves the adjacent bladder or the rectum, and stage 4B, it involves outside the pelvis. That was the classification. You can all see that. And this is a change which has made between 2018 onwards. Before 2018, the tumor size more than 4 centimeter was limited to B1, B2. And now, if it is more than 4 centimeter, that is 1B3. Similarly, the stage 3, C1 and C2, it was involving both the pelvic lymph nodes and the para-aortic lymph nodes. But now, if it is limited to the pelvic lymph nodes, that's a 3C1. And if it involves the para-aortic lymph nodes, that is the 3C2. That's why I always say, once the patient comes to you for even simple abdominal lymph node pathology, we should look for 2 things, very, very important. Number 1, if it is a male, look for the scrotum, because the seminomas, they come to you with the history of hydronephrosis because the lymph node sitting on the, or if there is a cervical pathology, please look for the downstairs first before you go for the biopsy, unless until the history is known to you. These were the old-fashioned investigations, ma'am, which used to be carried out, involving barium enema, IVU, lymphangiography, chest skeletal radiographs, and invasive procedure like cystoscopy, erectoscopy. Now they are no more required at all. Only 2 investigations I'll share with you, and you can reach the diagnosis. Number 1, transabdominal ultrasound. Those who are doing the transabdominal ultrasound, even for CS cervix, please never jump to the TVS. Always start with transabdominal, because that gives a panoramic view, and that gives a whole view of the pelvis, the adnexal area, the lymph node, the ovaries, and the uterine size if it is bigger. High resolution ultrasound, transvaginal ultrasound, TRUS. That is the upcoming modality. Let me share with you, it is indication in 2 things. Number 1, those unmarried young girls who are suspected to be case of PCOD, we can't do the transvaginal ultrasound, and we can't have high resolution on transabdominal ultrasound. The best approach is go for transrectal. It is as high resolution as transvaginal to see the follicular activity and the endometrial activity if you are suspecting any girl with PCOD. Similarly, as the mass is grade 2B, it is involving the upper part of the vagina. As you introduce the probes, the patient starts bleeding, so you can go to the TRUS, and the sensitivity I'll share with you in the next slide. That is the upcoming modality, as we are using in the case of liver, contrast enhanced, because certain patients, they do have the because the renal involvement serum creatinine is high. So this is a contrast 2C is given, exactly same picture as we see in the CT for the liver pathology, phase 1, phase 2, phase 3, 16 second, 20 second. I'll show you the image. And MRI. So ultrasound and MRI are sufficient, but sometimes you need the PET CT scan to stage the disease for metastatic disease, which cannot be seen by this simple MRI. How it looks on the ultrasound, very, very important. Normally, it is smooth in outline. It will be comparatively more hypochic. Hypochic means more black. More black means more vascularity. More vascularity means more blood flow. That means there is some mitotic activity going on. Heterogeneous involves cervix, may show increased vascularity on current Doppler. Normal cervix, they show minimal blood flow at the periphery, which is because of the arcuate vessels. Very minimal flow at the level of the interface. But in this case, you will see rich blood flow. Ultrasound cervical cancer stage clinically, however, ultrasound is useful. Either size is less than 4 centimeter or more than 4 centimeter. Very clarity, you can see that. You can appreciate the parametrial vision, which you can't see physically. Into the vagina, you can see that. Tumor invasion to the adjacent organs and hydronephrosis, sometimes patient present with the 3B stage. Just to show you this article published in 2008, look at it 14 years back. Transrectal sound and MRI, they were compared with each other, and the sensitivity goes to 85%. So that is a tool which is totally non-invasive, bedridden, bedside facility available, no sedation, no risk of putting into the MRI. Just do the transrectal ultrasound, and you can diagnose not only this local disease, even the parametrial involvement as you show. But the high resolution ultrasound TVS is equally good. But as I say, it is involved the vagina.